This video is sponsored by Bootcamp.com. Check it out for INBDE prep and use coupon code MENTALDENTAL for 10% off. Hey everyone, Dr. Ryan here. I wanted to make this video to simplify the world of periodontal flaps. There are a lot of weird names and terms and applications, and I'm going to explain all of that in the simplest way possible so you can approach every question on your board exam that asks about flaps with confidence. So first, I'm going to break down the different categories of flaps. We can first classify them based on the amount of tissue content contained within the flap that's raised, either full thickness or partial thickness. We can also classify them based on final placement of the flap, either non-displaced or displaced. And finally, we can classify them based on papilla management, either conventional or preservation. So let's dive into each of these categories a little bit more in depth. So first we have the full thickness flap. This is also called a mucoperiosteal flap because it lifts both the mucosal tissue and the periosteum. Periosteum is the membrane of nerves and blood vessels that tightly wraps the bone. So the full thickness of soft tissue, including that highly vascular periosteum, is reflected to expose the underlying bone. This type of flap is indicated when you need access to the bone for osseous resection or basically any time you need to modify the surface of bone. It's contraindicated in areas where the alveolar bone is already thin and dehiscence or fenestration is likely. Partial thickness. So the partial thickness flap is also called a split thickness flap or a mucosal flap, and this is where only the mucosal tissue is raised within the flap itself. So the epithelium and a layer of underlying connective tissue is reflected, leaving the vascular periosteum intact. And this provides a vascular bed for a grafting recipient site, which we'll talk more about later in the video. A displaced flap. So a displaced flap is where the flap is repositioned or displaced coronally, laterally, or apically to its original position. These flaps involve vertical incisions that increase the mobility of the flap and allow you to move it around. Importantly, these vertical incisions should extend into the alveolar mucosa beyond the mucogingival junction in order to reflect all of the attached gingiva and to allow for the flap to actually become displaceable. Both full thickness and partial thickness flaps can also be displaced. But to do so, again, the attached gingiva must be totally separated from the underlying bone. Interestingly, palatal flaps cannot be displaced because of the absence of unattached gingiva. Of course, the opposite of a displaced flap is a non-displaced flap, and this is when a flap is returned and sutured back in its original position. We'll talk more about why this is used when we talk about the specific undisplaced flap later in the video. Conventional flaps. This is where the papilla is split between two adjacent teeth, allowing the reflection of both a buccal and a lingual flap. It's indicated when the interdental space is too narrow to try to save the papilla, or when you just need that extra amount of reflection. The downside to this design is it can lead to the formation of black triangles, these little spaces between the papilla and the interproximal contact. Specific examples of this type of flap include the modified Widman flap and apically positioned flaps, but we'll get into those a bit more later. And lastly, the Papilla Preservation flap, where conventional flaps involve an incision right through the papilla from mesial to distal. These three lines here show three possible methods of papilla preservation to try and save the papilla and limit the formation of black triangles by cutting around them. This red line here shows an oblique cut from the lingual line angle of one tooth to the facial line angle of the adjacent tooth. The blue line shows a scallop from line angle to line angle on the lingual surfaces of these teeth, and the green line shows a scallop from line angle to line angle on the facial surfaces of these teeth. All right, now that we've broken down the different categories of flaps, let's go over some specific examples of different flap designs and applications that you'll see on the board exam. First, we have the coronally positioned flap. This is a type of displaced flap, and it's also called the coronally displaced or coronally repositioned flap. There are actually various techniques for doing this. As you can see, those two pictures are vastly different from each other, but the reason for doing it is pretty straightforward. You coronally advance gum tissue toward the teeth in order to cover a recession defect for one or multiple teeth. And you can do this by making vertical incisions and pulling the tissue over the root surface, or you can make a series of semilunar incisions and raise the entire flap to cover multiple adjacent teeth at once. The laterally positioned flap is also called a laterally displaced flap, a pedicle graft, or a double papilla technique. And this one is for small, single tooth recession defects only. And in the most basic sense, it involves taking the gingiva in front of one tooth and pulling it in front of another tooth. And this displaced flap is almost always preferred for covering recession defects because it's easier, causes less damage to the tissue, and you have a better color match because the gingiva is coming from the same vertical level, so it's great for anterior aesthetics. It's probably most often performed for covering the lingual surface of a mandibular anterior tooth that has experienced recession. All right, and then we have the apically positioned flap. It's also called the apically displaced or apically repositioned flap. One function of the apically positioned flap is that it reduces or eliminates a pocket by apically positioning the soft tissue wall of the pocket. So unlike an undisplaced flap or a gingivectomy that just cuts out the pocket wall, this flap preserves the attached gingiva and transforms the previously unattached keratinized pocket wall into attached tissue. In most cases, the mucogingival junction also gets displaced apically as well. This procedure can also be performed to expose an impacted tooth, as seen here for orthodontic purposes, or as part of a crown lengthening procedure. The benefit of using it with crown lengthening is the same benefit when it's used for pocket reduction. We preserve the attached gingiva without having to cut any off. Next, we have the modified Widman flap. This flap facilitates instrumentation for scaling and root planing therapy, also known as surgical debridement of plaque and calculus. This flap itself does not attempt to reduce the pocket depth, but it does eliminate the pocket lining. I know this probably sounds confusing, so let me explain. The original intent of this flap is to access the root surface for the best scaling and root planing possible. In addition to that, the internal pocket lining is cut out via gingival curettage, removing any granulation tissue with it. The remaining flap is placed back where it started and sutured in place. So again, the flap design doesn't reduce the pocket depth at all, but removing the irritants with scaling and root planing and the irritated tissue with curettage can over time lead to shrinkage of the pocket as everything heals. So indirectly, it can lead to pocket reduction. So I wanted to make that important distinction for you. Finally, let me talk briefly about the 3 different cuts that are involved in this flap. First, we have the internal bevel or reverse bevel. Bevel means it's sloping at an angle, internal because the slope is headed inward toward the tooth. It's about 1 millimeter outside from the gingival margin, and it removes the internal pocket lining, yet conserves the outer gingiva. Just so you know, an external bevel cut would be oriented like this. And that would be used for a gingivectomy to cut away excess gum tissue. Next, we have the sulcular or crevicular cut, and this is made through the base of the pocket to the alveolar crest. And lastly, we have the interdental or interproximal cut, which removes the collar of tissue around the tooth that you created with the first two incisions. So then you can pull off that section of soft tissue. And then, of course, you would take the remaining soft tissue and suture that back in place once the scaling and root planing has been completed. All right, next we have the undisplaced flap, and this is currently the most commonly performed flap in periodontal surgery. So why is it done so often? Well, one reason is to temporarily get the soft tissue out of the way in order to clean the root surface, kind of like the modified Widman flap. But it can also be used to remove the entire pocket wall, as a result, reducing or eliminating the pocket altogether. And this is where it's different from the modified Widman flap. Look at how much deeper this incision goes. It's essentially an excisional procedure of gingiva, and some call it an internal bevel gingivectomy because, again, the direction of the cut is beveled inward toward the tooth. The important distinction between this and the modified Widman flap that I just alluded to is that the cut goes below the crest of bone, whereas in the modified Widman flap, that initial internal bevel incision was made to the crest of the bone. So this flap is a bit more aggressive, it's taking more gingiva away, and it's also less technique sensitive. The modified Widman flap is a lot harder to master. Now, different amounts of gingiva can be removed with the undisplaced flap, but we want to make sure there's enough attached gingiva that's left behind after removing the pocket wall. So we always measure the depth of the pocket and the width of attached gingiva before carrying on with an undisplaced flap. All right, the semilunar flap is a conservative flap design where you make a crescent-shaped incision in the alveolar mucosa paralleling the gingival margin. For the board exam, you want to connect this flap design with apicoectomies, also called root end resections, and they can also be used for the removal of small apical cysts or root tips. The envelope flap is the most commonly raised flap in oral surgery for tooth extractions. Why is that? Because it's quick and easy. You use the scalpel in the sulcus of the tooth to be extracted and the adjacent one or two teeth on either side, and then use your periosteal elevator to get the tissue out of the way so you can see what you're doing. Also note how there are no vertical releasing incisions needed in this flap design. And then once you're all done, you suture it back to its original position. So technically, based on our definitions from before, this would be a full thickness, non-displaced flap because the flap includes both mucosal tissue and periosteum, and its final position will be the same as its starting position. The distal wedge procedure is done distal to the terminal molar of a quadrant, so in other words, the most distal tooth. And it's most commonly done after a wisdom tooth extraction. And that's because there can be some extra thick operculum-like tissue left once the wisdom tooth is taken out, forming a sort of pseudopocket. And so this procedure cuts out a wedge of tissue to reduce the depth of that pocket so it's easier for the patient to maintain good periodontal health back there. In the maxilla, the incisions are made parallel to one another. In the mandible, they are made to form a triangle. Definitely remember those two things for the board exam. One easy way to remember this is to say Distal Wedge. Really emphasize the L when you say it. And then check this out. The word maxilla has two L's together, and so does the word parallel. And mandible only has one L, triangular only has one L. So a nice little memory trick there to help you remember those two things. The last two flaps we're going to go over are not technically flaps, they're grafts, but I wanted to include them because they're high yield and they involve flaps as part of their technique, so we can apply what we've learned up to this point. Grafts are, in the most basic sense, borrowing tissue from one place that can spare it and transplanting it to another place that needs it. Free gingival grafts are used to widen the band of keratinized tissue around teeth, usually in the mandibular anterior. For clarity, keratinized tissue includes the free gingiva and the attached gingiva that make up about the first 3 millimeters or so of gingiva next to each tooth. If it's reduced and only, let's say, 1 millimeter thick, then that could be an indication for doing this kind of graft, to widen it. 3 really quick terms for you. So donor site is where the tissue is coming from, recipient site is where the tissue is being placed, where the graft is needed, and the graft site is after the tissue has been sutured in place. So the donor site for a keratinized tissue is often the posterior hard palate and involves a split thickness or partial thickness flap to leave the periosteum intact so that tissue can fill in on its own over time. And the fatty submucosa layer is also left behind, which can compromise the graft if it's included in that graft layer. So really, you're just getting the epithelium and the lamina propria. The recipient bed is also a partial thickness flap to leave periosteum intact in order to feed the graft tissue. And sutures are used to immobilize the graft onto the recipient bed. If the graft moves, it will fail. So you have to suture it firmly in place. And lastly, we have a connective tissue graft, which is used to improve root coverage for recession defects. The donor site is once again usually the posterior hard palate, but this time you only harvest the inner subepithelial tissue. So literally just the lamina propria. So it's a lot less painful for the patient during healing. Then the recipient site can be prepared with a split or full thickness flap with dissection beyond the mucogingival junction. You would pair this procedure with a laterally positioned, or in this case, a coronally positioned flap, and then fix the harvested graft tissue underneath that flap with sutures. The post-operative image shows a successful reduction in root exposure. So, a quick summary of what we talked about. These first two here are for covering gingival recession defects, and the main deciding factor between them is how many roots you need to cover. Either of these can be paired with a connective tissue graft in order to improve success. The next 3 are flaps that are designed for pocket reduction. But remember, the modified Widman flap is more so for access for good quality scaling and root planing, and the pocket reduction comes later from healing after the scaling and root planing, not from the flap itself. The main deciding factor between apically positioned and undisplaced is the width of attached gingiva that you have at your disposal, and whether you can afford to cut some off with an undisplaced flap, or if you need to preserve it with an apically positioned flap. The semilunar flap is for apicoectomies, envelope for extractions, distal wedge for terminal molar pocket reduction, free gingival graft to widen the band of keratinized tissue, and once again, connective tissue graft for root coverage. All right, and I didn't want to let you go before testing what you learned. So let's do some practice questions. Question number 1. A patient has a deep pocket depth. Which procedure would reduce the pocket depth while preserving the gingiva? Go ahead, pause the video, think through this question, and then we'll go over it together. All right, so in these answer choices, I'm seeing gingivectomy, which would reduce the pocket depth by removing gingiva, and here we're trying to preserve it, so that would not be correct. The undisplaced flap, similarly, would reduce the pocket depth, but once again, we're removing a lot of gingiva, so that can't be correct either. And then we're left with the 3 displaced flaps. Coronally positioned would decrease recession, but actually increase the pocket depth by stretching the tissue toward the tooth. Laterally positioned would keep the pocket depth the same. Apically positioned would decrease the pocket depth while preserving the gingiva. So the answer to this first question is B. And then question number 2, my last question for this video. What flap design is optimal to repair an isolated gingival recession in the anterior region? Go ahead, pause the video, think through this question, and then we'll go over it together. Okay, so for gingival recession, we're thinking either coronally positioned or laterally positioned, and only one of them is an answer choice here. So a pedicle graft, also called a laterally positioned flap, is best to repair an isolated gingival recession and gives you even better color matching for an anterior tooth when you compare it to a coronally positioned flap. So the answer to this question is B. Alright, so that's all I have for this video. I hope it helped you better understand periodontal flaps and what they're used for. You may get several questions on these on your board exam, so hopefully you can remember this video when it comes time for test day. That's it for this video. Thank you so much for watching. Please like this video if you enjoyed it and subscribe to this channel for much more on dentistry. If you'd like to support me, please check out my Patreon page. And thank you to all of my patrons for their support. You can unlock access to my video slides to take notes on and practice questions for the board exams, so go check that out, the link is in the description. Thanks again for watching everyone, I'll see you in the next video.